This
Occupational
conference
Therapy
will now be recorded.
at the Mass Gen Health Institute of Health Professions. Um, and she has a lot of research and expertise in upper extremity neurorehabilitation. So uh, we're just gonna give the mic over and the presentation to Dr. Fasoli as she has prepared something for us. And I would like to remind everyone that we are recording this webinar, so it can be accessed by members at a later time. And you can, if we can leave all our questions towards the end of the presentation, there's also a chat box that you can type your questions into that we can help moderate for the discussion. So without further ado, Dr. Fasoli, you have the floor.
Okay, all right. Thank you, Maria, and thank you for inviting me to do this, Veronica and others. I'm happy to be here. So the talk that I'm giving today is just a paradigm shift, talking about rehabilitation robotics and cognitive skills training. I'm trying to advance my slides here. It seems like I'm stuck, Maria, after all of that practice. There it goes. Okay. So just want to note a few disclosures for funding support that I've gotten for this research over the years, and to highlight the session objectives. So what I'm going to do today is to start really with just talking about the rationale for why robots have been developed for stroke rehabilitation to begin with, and some of the strengths and limitations of prior research. Going on to talk about motor learning principles, and thinking about principles that really guide both conventional rehabilitation and robot-assisted therapy. And then to introduce or talk about the co-op protocol, which is a cognitive orientation for occupational performance, and how that has informed my ALPS program that I've developed to integrate cognitive training and strategies with robot-assisted therapy to try to facilitate transfer of function from robot-trained skills to daily functional use of the weaker upper extremity after stroke. So just to start off, for those who aren't familiar with rehabilitation robots, there are actually two main classes of robots that are used for rehabilitation. The first class is really compensation. And so the pictures that are here just show a picture of the BrainGate system, which is a system that I've had the opportunity to work with these individuals that, in this case, they actually are implanting an array that measures cortical activity on the motor cortex to allow individuals with ALS, or with this woman, locked-in syndrome, to be able to operate a computer cursor on a screen to communicate, and in this case, to be able to control an assistive robot. And so for anybody who would like to look at this later, there's a link down here. There's a great video that just shows some of this work in action. And then these are other compensatory robots that help to facilitate reach and grasp, et cetera. This is the JACO, which is another rehab robot that we have used in conjunction with the BrainGate system. The other class of rehabilitation robots, and the one that I'm going to focus on today, is really focusing on restoration of lost motor function. So examples of those are the Armeo Spring, which I've been using for my current project, and the InMotion arm. So these robots really focused on impairment reduction. So the idea is to provide repetitive practice and to hopefully restore neuromotor pathways after stroke. So the rationale for robot development began many years ago, back in the early 1990s, with people at MIT, which is a group that I had worked with, really starting and developing the first rehabilitation robot, which is the MIT Manus, or the InMotion arm, as it's called now. But what drove this development was evidence that neural recovery actually can occur in response to intensive rehabilitation, even in individuals with chronic stroke, and that behavioral experience and practice can really contribute to structural reorganization and brain plasticity after stroke occurs. And that we all know through our practice that we really need interventions that can deliver challenging, motivating, and yet cost-effective movement therapies. In the time that I've been practicing lengths of stay have significantly decreased, and the attention that is paid to upper extremity rehabilitation and inpatient rehab has diminished significantly, with a focus on discharge and improving functional status and ability to get home to a safe environment. So we know that these repetitive movement therapies are really labor intensive and expensive to deliver in inpatient settings. And so the idea of proposing semi-autonomous robotic therapy, where you could have one clinician overseeing a number of different robots being used simultaneously by different patients, was one approach that's been proposed by engineers and neurologists. Robots are able to give programmable levels of assistance or resistance training, and you can get good information about knowledge of performance and knowledge of results from the data that you gather from the robotic device. Robots also provide quantitative measurement of motor function, so you can get measures of coordination in terms of speed and accuracy, and the data that we get from the robots like the InMotion robot really can help us to understand some of those mechanisms of recovery, whether we're seeing restitution of function or the use of compensatory strategies. So it's really helpful to have these devices to provide that repetitive training and to give us some data that could be used for documentation as well. And we know that persistence with prolonged motor rehab is really challenging, that learned non-use is developed or occurs very early after stroke occurs. And so combining robotic therapy with goal-directed games that are engaging can help to improve motivation, to continue to try to improve motor function in that weaker arm and hand. And then finally, motor learning studies in humans have indicated that people need 300 to 800 repetitions a session for motor learning to occur. And that this motor learning doesn't just require skill acquisition, as we measure immediately at the end of a session, but it also requires retention and then transfer training to untrained tasks. And so when we think about some of our traditional assumptions about transfer of trained motor skills to functional tasks, I know I've always, in years past, thought that if you reduced impairment, you would automatically improve functional performance. And that is truly not the case. And I think that our role as clinicians is really to help individuals see that as they are recovering some motor function and regaining some movement in that weaker upper extremity after stroke, that they really need help in transferring them, those improved motor skills, to those daily activities. It doesn't automatically happen. But when we're in stroke rehab and challenges that we're facing, we don't have necessarily the time to be able to do that. So the challenge is really to figure out, well, how can we use these devices effectively and have good research evidence that will support their use in clinical practice. So what I want to move on to is just talk about robot-assisted therapy for adults and what is the evidence that we have seen, and really thinking about this from more of a theory-based perspective. So I'm sure that you're all familiar with the International Classification of Functioning, the ICF. This provides a structure for looking at function across domains, including body functions and structures, activities, and participation. The challenge with the ICF is that while it helps to guide our evaluation of performance and to look holistically at the functional needs of individuals, it doesn't provide us with any way in which to examine the interventions that are provided and the effectiveness of those interventions. The Rehabilitation Treatment Specification System does provide a framework to explore that black box of rehab. This is a theory-based approach that I would assume that everybody's familiar with. That's been the hard work and effort of John White, Marcel Dykers, Tessa Hart, starting as an ACRM task force more than 15 years ago. And, you know, I've had the fortunate experience of being involved with some of the development of this, but I think it's a really nice mechanism for us to both look at the causality of what we expect to see in terms of our interventions, thinking of how we describe and really understand the ingredients of our intervention, to be able to think about, well, what are the potential mechanisms of action, or how do I think this treatment is expected to work, and what is the target? What is it that I'm actually hoping to affect change in? The process of treatment specification sort of works the other way, the other direction, in terms of when you're thinking about identifying treatment ingredients, you start with that target. What is it that I want to affect change in? And then based on that, we as clinicians pick the ingredients that we think are going to be the most effective, whether it's repetitive practice, whether it's ADL training, whether it's gait training, etc. But then being more specific with those ingredients and what they are can help us to better understand what those mechanisms of action are and understand how that treatment is expected to work. And so what I've done in thinking about robot-assisted therapy is I've applied this model, the RTSS, to really think about, well, what is it that we are doing when we're providing robot-assisted therapy? And is all robot-assisted therapy the same? And it's really not. If you think about the ingredients that are delivered by rehabilitation robots, you have this human-machine interface. That may be an exoskeletal device, such as the Armeo spring that attaches to the upper arm and the forearm. There's a grasp sensor here that can detect grasp and release during games. Or there are these end effector robots, like the in-motion arm robot, that only attaches to the person at one distal point. So it's not controlling degrees of freedom or quality of movement throughout the upper extremity. It's just really looking at where that distal part of the hand is actually moving. The type of assistance also differs across robots in that some provide gravity support, as seen in the Armeo spring. These are springs that just unweight the arm so that it makes it easier for the individual to practice repetitive movements. And then there are other devices like the InMotion, or this is the Armeo Power over on the left, that provide an actuated assist so that the motors actually help to provide assistance when the individual has a hard time moving. And because of the mechanics of some of these devices, they can also provide opportunities for resistive exercise for individuals who may benefit from that. And then if you look across studies, the treatment dose in terms of the number of repetitions, the frequency or duration of the intervention is often very different. And the workspace in terms of doing planar exercises, as is done with this in-motion arm robot, it's only, exercises are only performed in a horizontal plane versus spatial exercises and incorporated in reaching. All of these ingredients could contribute to different effects in terms of function. I mean, we really don't understand which are really the most effective for a particular patient, or what may be indicated for somebody who has more versus less impairment. Also, the computer-generated games provide some great motivation and feedback, as is seen in some of the Armeo Spring games and the Armeo Power games, whereas the computer-generated games for the Armin are more basic kind of dot-to-dot movements that are more repetitive and aren't as much of a game like saving the monsters from a raging fire. So the ingredients certainly feed into both participation and potentially outcomes, although there's never been any studies that really have been able to evaluate one robot against another. Other things that we think about in terms of robot therapy are the targets of the intervention. And so as clinicians, our target is to improve somebody's functional abilities after stroke. But if you look at the targets that have been documented and published after robot therapy, that we really are focusing more on impairment-based measures. And we're looking at proximal versus distal motor function, because we've either done a lot of training of shoulder and elbow movements versus hand movements. There is not one device that provides exercise for all parts of the upper extremity at the same time. There's also targets, motor coordination and control. And so there are ways in which you can set up some of these devices to provide single action. So you can just focus on simple elbow flexion extension versus multiple joint control. So you can actually control the degrees of freedom that are practiced and work on interjoint coordination. And then volition is certainly a target, especially for people that aren't particularly motivated to follow through with exercises at home, or they're facing depression and some levels of decreased endurance and engagement. That volition is a target that is an important target for robot-assisted therapy. When we think about the outcome measures that we're using to understand the robot's effect on these targets, we're looking at measures that are at the capacity and performance levels as defined by the ICF. So we're using standardized assessments like the Fugl-Meyer, the ARAT, some kinematic measures to look at changes in motor capacity, and then also evaluating changes in performance at home via the motor activity log, etc. So the challenge, though, is that with robot treatments, they typically do not include problem solving and focus on transfer of functional use, the paretic upper extremity to daily activities. And so that's one of the things that I think has been a real limitation in a lot of the previous studies. There's been more of an emphasis in the last few years on combining robot-assisted therapy with task-oriented training, but I'm still not sure the degree to which that task-oriented training is really providing people with the skills needed to facilitate that transfer, to understand how these gains that we're seeing in the impairment level or body function level of performance can really translate over into daily use of the affected arm. And when we think about mechanisms of action, continuing with this RTSS model, that mechanisms of action is really why you think that treatment, intervention, and those ingredients may work to have an effect on your target. And so they may or may not be observable. But some of the things that we really are thinking about in terms of robot therapy are that this repeated practice ingredients really helps to facilitate skill acquisition. And the mechanism of action that's proposed is this learning by doing. It's pretty vague, but that's the kind of thing that we're trying to understand. Are we seeing cortical changes as a result of this intervention? Certainly the kinematic measures that we are getting after robot-assisted therapy give you some sort of a surrogate measure of changes in cortical ability and functioning, but we still really don't know a lot about those true mechanisms of action. But we do know that some of these ingredients in terms of education, using engaging robotic therapy games, instructing individuals how to perform therapy tasks, does have an effect that our targets in those cases are really increasing individuals' knowledge or motivation, and we're addressing that through improving this information processing. So in just thinking about using the RTSS to describe and explore robotic interventions, I think is one way of also looking at the research that has been done and published, and trying to understand, well, what are some of the strengths and limitations of that research? So I'd like to take just a few minutes, and I feel like I'm talking really fast, but I want to take a few minutes and just talk about upper limb robot-assisted therapy and what some of the research evidence is to date using this RTSS framework. So when we think about targets and outcomes that have been described in research, we find that systematic reviews really confirm that robot-assisted therapy elicits significant, statistically significant, but generally modest reductions in motor impairment and improvements in performance, and that those are primarily observed at the ICF level of body functions, not at the participation and activity levels. And that the greatest gains that we have seen have been primarily in motor capacity as measured by the Fugl-Meyer, or kinematic studies that have been done that have documented changes in speed or smoothness or isolated control after stroke and after the intervention. The majority of this research has examined the effects of robot therapy on proximal upper limb training, that we have had to date fewer robots to exercise the wrist and hand, so that those distal training, it's great to be able to train reaching to get that arm out to a specific target, but if we're not helping individuals to retrain grasp and hand function after stroke that we're not really addressing all of the functional needs for the individual. And then if we think about those targets, that the target, as I said, is really impairment reduction rather than functional use of the paretic arm and its impact on participation. When we think about the mechanisms of action and factors that influence outcomes, certainly we know that this highly repetitive movement therapy is needed for motor recovery and motor learning to occur. And we see these changes in motor capacity, but you cannot assume that changes on the fibrometer or improved ability to move the weaker arm is necessarily then associated with functional performance gains, that people need, I think, help with translating those skills to functional everyday activities. And that there's a specificity of training effect, that generally what you train is what you get. And so generalization to untrained limb segments or upper extremity ADLs is not well supported by the literature. We've found, or I've found, that individuals with less impairment and greater manual dexterity are more likely to achieve clinically significant ADL improvements after robot therapy. And I think that's because they have more residual cortical functioning that's present. And that certainly we know that the timing of intervention matters, and that sooner after stroke is better than later. So when I'm thinking about these mechanisms of action and targets and ingredients, I'm thinking about clinical practice. I think that it can help to inform clinical practice in how we deliver care or think about what is needed for care in inpatient rehab settings. You know, we know that inpatient rehab length of stay is really limited. You know, here in Massachusetts, we're lucky if we have somebody for 3 weeks after stroke inpatient. When I first started practicing a number of years ago, we'd have somebody there for 2 to 3 months. We know that highly repetitive movement training is really difficult to implement in a clinical setting. And Debbie Rand and others have shown that an average of only 32 repetitions of upper extremity movement were reported during inpatient and outpatient settings. And so that's not sufficient for true motor learning to occur. We also know that accelerometry measures that show changes in the ability to use or the amount of use in the paretic arm don't necessarily transfer to increases in daily use. So the question is, how can we optimize patient outcomes, and what are some of the differences between the ingredients of this robot-assisted therapy versus conventional practice? I think probably everybody on the call is familiar with Kleiman Jones' article and discussion of the principles of exercise-dependent neuroplasticity back in 2008. And so I think that this is a model that is very useful to occupational therapists to think about why we use occupation and what are some of the important characteristics to consider when we are providing intervention for somebody after stroke. It also provides us a way of looking at functional recovery as a relearning process. And so some of these principles are, use it and improve it. If you don't use that weaker arm after stroke, you're not going to see any gains in performance. Specificity of training, we've talked a bit about, in that specificity of training really is that what you train is what is likely to improve. So if you want to improve fine motor skills, you need to practice fine motor skills. And we all know about repetition and intensity as being important. And one of the things that I think a lot about is, as an OT, is the salience of the training activities. Are these really relevant and important to the individual? And have I helped them to transfer skills that we've practiced to everyday activities at home and in the community? So if we think about conventional practice versus robot therapy, typically our targets in conventional practice are really at that activity or occupational performance level. We typically have clear upper extremity ADL goals, at least in OT. And the principles behind that are certainly use it and improve it. There's a high specificity of training because we're using the real life activities for therapy. And there's a high salience or relevance to their daily lives. We're using real tasks and object manipulation during therapy, so this tends to be a higher transference, but also low repetition and lower intensity. And if we compare that then to rehabilitation robotics, the target for rehabilitation robot therapy has typically been impairment reduction. So in robotic therapy, we do a lot of goal-directed movement training, again, focused on use it and improve it, high specificity, but there's low salience of that training. And also the repetitive practice and the active assistance from the robot is very helpful. It's allowing for high repetition and intensity, but again, it's low transference. It's not a focus on how then do I transfer these skills. So you can see how these are very different focuses of interventions that could potentially be complementary. So in thinking about robot-assisted therapy and all the years that I've been engaged in it, that I think many of these principles, or several of these principles, have been largely ignored in these previous studies, particularly salience and transference and specificity of training effects. That we know that self-efficacy and motivation and meaningfulness are critical to the development of technology. I've had many discussions with engineers who developed the MIT Manus that we need something other than these repetitive dot-to-dot movements to stimulate motivation and to help people to really be engaged in that training. And that we've also seen in recent years that shift toward combining robot-assisted therapy with task-oriented training and incorporating more of these principles of exercise-dependent neuroplasticity. But when I really stop and think about what is needed for transfer, I've hypothesized that it's really that we need to engage in cognitive strategy training, and that may be an essential yet missing ingredient for these prior robot-assisted therapy trials. So I want to talk just for a few minutes, and I'm watching my time, and I want to talk just a bit about the co-op program and cognitive strategies to improve recovery of motor function and functional activity after stroke. So the cognitive orientation to daily occupational performance, or co-op, is a contemporary learning approach that's been used to improve motor skill acquisition and function. It was originally designed for kids with developmental dyspraxia and has been expanded over the years to a variety of populations. This work actually started in Canada and has continued here in the US as well. So some of the key features of this cognitive orientation to occupational performance are its client-centered approach. It uses activity and occupation-based goals. There's a process that they refer to as dynamic performance analysis that helps individuals to work with you as a clinician to identify performance issues and potential solutions. There are both global and domain-specific strategies that I'll talk a bit about. And the process and the role of the clinician is not to do for the client that you're working with, but to facilitate active problem solving, active learning through this guided discovery process. And that if we are not empowering our patients or clients to engage in that active problem solving and providing them the skills that they need when we're not there with them, then I think we really haven't done them justice in doing the best job that we can to try to optimize their functional abilities at home. And one of the other key strategies or components of this is caregiver education, to have caregivers reinforce strategy use and transfer of the training they've had in the clinic to home environments. So there are a number of enabling principles that co-op utilizes, including the fact that therapy should be fun and engaging, that there's a focus on learning, and the real aim is to facilitate generalization and transfer. And there have been a number of studies that have been published that demonstrate significantly improved occupational performance in adults and kids who have neurologically based motor impairments and developmental disorders. So there's evidence out there that this approach works in the context of more task-oriented training and learning. But it's never been explored in terms of using it in conjunction with robot-assisted therapy. Some of the examples of dynamic performance analysis are demonstrated here. The purpose of this DPA, as it's called, is to really help individuals to identify factors that can impact performance and to have them identify potential strategies that can improve skill acquisition and transfer. The collaborative process that happens between the client and the clinician, and it's really based on observation and analysis of performance. And so it's almost like teaching your clients or patients to do their own activity analysis and their own movement analysis so they can figure out, well, what's not working and how can I better use this hand, even if it's just as a functional assist to accomplish something that I'd like to be able to do at home. And there's an iterative process that involves reflection and explicit analysis, really working together to analyze what was it that caused that problem, and then how do you, what might be some options for improving your performance by identifying those difficulties that they had. So some of the global strategies, the ones that have been used with co-op, are to identify a goal. So first, before you even start the activity, you identify what is the goal that I want to accomplish. And then you work with the individual to decide on a plan. Well, how are you going to accomplish that goal? And then to do the activity, and then to troubleshoot when there are challenges. So if I set a goal for putting on a shirt by myself, and I have a plan where I'm going to put my weaker arm in first, but then I run into a problem because I haven't pulled that shirt sleeve and shoulder up over my shoulder before I tried to pull it around, that I can start to troubleshoot some of those difficulties and come up with a new plan and just check and see if that new plan works. So domain-specific strategies really involve things like changing your body position, focusing your attention on a particular aspect of the activity, modifying the task, or providing some verbal instructions or self-instruction, talking yourself through the activity. So these cognitive strategies with co-op have been found to be quite effective, as I said, in the context of task-oriented training. Some of the evidence has shown that there have been gains in both motor capacity that are not spontaneously used during everyday activities. So some of this kind of preceded co-op, but we know that some of that evidence led to the use of co-op and finding that using co-op with task-oriented training or task-specific training can improve that transfer to untrained upper extremities. Lynn Gauthier and others who were very involved with the CIMT early studies found that the transfer package that they used with both CIMT and video game rehab yielded improved upper extremity performance, both on measures of motor body function as well as activity level performance. And Tim Wolf and others found that co-op guided discovery and task-specific training actually improved upper extremity motor capacity on the ARAT as well as performance on the stroke impact scale. So we're finding that these approaches are really helpful to individuals, but as I said, that they had not previously been applied to individuals after or during robot-assisted therapy protocol. So hence, my development of the active learning program for stroke, or what I call the ALPS program. So what I've done in the pilot work that I've done in the past couple of years is really to take the co-op strategies and develop a way of integrating this approach with robot therapy. I found that setting goals didn't necessarily work with patients, that very often people in their real lives run into a problem when they're trying to use their weaker arm. They don't initially start with thinking, well, what is my goal? What do I want to accomplish here? And how am I going to use this weaker arm? So it's a bit more focused on integrating the paretic upper extremity during daily activities rather than just a focus only on task-oriented or on task performance. So what the goals of this initial pilot were to define or develop and refine this protocol. And the first go-round, we actually had 10 individuals that we enrolled. Half of them got just robot therapy, and the other half got robot therapy and task-oriented training. Everyone in both of the groups received this active learning program for stroke, where they were given strategies. We worked on identifying activities that they would do at home to work on active problem solving, and we had our own set of global and domain-specific strategies that we worked on during therapy. So the primary goal of this initial work has been really just to try to pull together a protocol and to examine the feasibility and adherence to the protocol, and then also to examine the effects of this intervention across ICF domains. They're using measures of motor capacity and performance, and using accelerometers to look at changes in performance at home as quantified by wearable sensors. So in thinking about this active learning program and using these principles of experience-dependent neuroplasticity, these are just some of the examples of ways in which I tried to pull in these motor learning principles in conjunction with the co-op training. So in terms of use it or lose it, we focused the training on individuals being able to identify interfering and changeable impairments. What could we really affect a change in? And if somebody had, impaired motor function that affected grasp and release, we weren't going to be working on writing, but we were going to be working on maybe using that hand as a functional stabilizer or using it during bilateral activities. That we focused on establishing clear patient-centered goals for what they wanted to be able to do at home, and really facilitated this upper extremity management through the active problem identification and problem solving. We chose activities that were motivating to individuals, and we really addressed self-efficacy and confidence every week when we were addressing new goals and identifying some of the challenges that individuals had faced. So this is a randomized controlled pilot study with a repeated measures design. We incorporated or enrolled 10 individuals with chronic motor impairments, moderate impairments, between the ages of 25 and 82, which is a wide range, but we had, of those people, there was not a significant difference in admission Fugl-Meyer scores based on age. And we also, as I said, provided robot therapy, but the robot therapy was provided with the Armeo Spring, as shown here, and the Amadeo robot. And so we provided this blocked practice where the first 9 sessions were provided via the Armeo Spring exercises, and then the last 9 intervention sessions we did with the Amadeo to focus on both gross grasp and release and individuated finger movements for those who could participate in individual finger control. The activities that we chose for the home program, we actually based, at least initially, on work that Michelle Woodbury and Craig Veloso and others have done with the Fugl-Meyer. There's a Fugl-Meyer key form that they developed to be a rationalysis that identifies the level of difficulty of Fugl-Meyer items from easiest, elbow flexion, to most difficult, wrist circumduction. And so we use their baseline Fugl-Meyer scores to target the individual movements that we wanted to be able to address. We, to the best that we could, tried to address this range of movements with the Armeo Spring, because we could isolate out and really focus on elbow extension or supination pronation. And we also then targeted the home program to those activities that were achievable for the individual based on their initial baseline scores. The home program emphasized, as I said, these robot-trained movements and cognitive strategies during everyday tasks. We updated the home program weekly, and we monitored adherence via these written checklists and interviews. So we talked with people every time they came in, what was going well, what needed to be changed, etc. The form that we used evolved during this initial pilot. You can see that our problem-solving procedures down here were a little bit different than the co-op protocol, in that we really wanted people to be able to identify if they were having a problem with accomplishing one of the activities that they had agreed to practice at home, that they would stop, clarify the problem that they were having, and that they would think, well, what else could I try? Based on our conversations and based on their understanding of more domain-specific strategies. Perhaps if you can't reach to open that cabinet door because you need more shoulder flexion, that you can assist with the other hand, but you can actually work on that grasp and release of that cabinet door by providing a little bit of assistance. Or just focusing on working within your reasonable range of motion in terms of, well, I'm going to work on improving the reaching for and grasping the cabinet drawer at waist level and opening that so I can retrieve silverware in preparation for dinner. So we went through this process of stop, think, come up with an alternative. If you have a problem, do it. So try it again, even if you think it won't work, and then to check to see, well, what worked and how can you be more successful the next time. We had a focus initially on these activities to practice, which we would update every week, that we had people promise that they would practice for at least 30 minutes a day, which we thought was at least a reasonable place to start, and that people would agree on the number of repetitions, or amount of time that they would practice a particular activity, and they would check off whether they had attempted it and to note how much time that they had actually engaged in doing those tasks. Here, the movement targets were just giving them ideas of what to focus on during the activity. So if they were planning on just wiping the counter and they wanted to work on wrist extension and finger extension and maintaining that position while they were wiping the counter, that the movement target would be documented here as a reminder of what to really focus on in that movement. And then challenges and successes, we asked them to note if they had accomplished something that wasn't on their list that was, hey, I was able to do it. We asked them to note those and what went well and to note any of those new accomplishments. And then weekly, we would go through home action plan and have them talk about what had worked well, what strategies or solutions were effective and not helpful, and how confident they were that they could improve their performance, because that self-efficacy piece we thought was an important thing to keep track of and to help them to understand the kinds of activities or situations where they felt like they were more confident versus less, and how to address that. We found in terms of these preliminary findings that group differences were not significant on all assessments except for the Fuglemeyer. But we weren't really surprised by that, because everybody got the cognitive strategy training. But we wanted to explore and understand, well, where were changes and did changes occur across ICF domains? So when we combined everybody together with the rationale that, yes, they all received this cognitive strategy training, that we found significant gains on measures across all ICF domains, on the Fuglemeyer, the Wolf, stroke impact scale, et cetera. And that changes and gains that we had seen in self-efficacy, as measured by the confidence in arm and hand movement scale, had increased significantly at discharge, but were not retained at follow-up. So all of this demonstrated that the intervention was feasible, that it was well tolerated. Certainly you can't talk a lot about the effectiveness of this intervention yet, because it was a small sample size. And I did have some variable adherence to that home program across participants. Some were religious about it and would do hours of practice and would think how they could incorporate that arm and hand into every activity that they did. And others were less so. And so as a result of this initial pilot, I received some AOTF pilot funds to do a more refined protocol, and we're in the process of that and in preparation for applying for NIH funding. The new pilot is just looking at the effects of ALPS training with robot-assisted therapy versus robot-assisted therapy alone. So these preliminary findings indicate a need for this integrated approach, this theory-based approach to think about how we may optimize transfer of function from robot-trained skills to daily activities, and that some of the comments from participants provided some teaching moments for us. I had one woman who had told me that she had great ideas for functional things that she wanted to do, but she would come back into the session and she would say, no, I didn't do that. But I did exercise. I did my exercises. And when she finally realized that, no, we're trying to build new habits and helping you to use this weaker arm during everyday activities is building new habits. She said, it's a real true paradigm switch for me that I hadn't thought about. This is real therapy. So it was an interesting kind of eye-opener for me in terms of how we approach our patients and clients after stroke, and how we really need to think about the conversations that we have with them. So in terms of considerations for robot technology, interventions, I think that this reinforces the fact that the learning of motor skills results in adaptive changes in functional organization of the motor system, and that this cognitive strategy training may be an effective addition to robot-assisted therapy to improve everyday activities. And it was possible and was well accepted by participants. And in individuals who I invited back 1 to 2 years later, they actually told me that many of them were still using the same strategies in everyday use. So I feel like it had a long-standing effect. So in just wrapping up, that we know that rehab technologies provide this unprecedented data for modeling our treatment inputs and outputs. So it helps us to understand what those ingredients are, and being able to measure the target of our intervention, and it contributes to our knowledge of those mechanisms of action. But we also need to pay attention to patient-reported outcomes and self-efficacy when we are looking at the effects of our intervention, and that transfer of skills to real-life activities. And so with that, I'm going to end and open it up for questions. I thank you for your attention, and I hope I didn't talk too fast throughout this discussion. So thank you. So if there are any questions, I guess we could take those now.
Thank you, Susan, for that presentation. It's okay to talk fast. You had such a lot of information there to share. So
yeah, a lot there, yes.
Totally. I was going to start off with a comment on your ALPS work and how great it is, and to really mimic real life. Sort of really, these are what clinicians are faced with on a daily basis. Even with your anecdotal comments about patients coming in and having big plans for themselves and maybe not really sort of meeting that target. But it really, I thought, builds on pieces of intervention that we do have research on, and that whole problem-solving piece, that self-efficacy piece and self-management piece is very important. I thought that was such a great addition to like a motor control type of activity. So what a great endeavor.
Thank you. Thank you.
Does anyone in the group have any questions? No, sorry. Go ahead, Susan.
I was just going to say that in the years that I've been engaged in this robot-assisted therapy and working with engineers, that it's been a great learning process for me in terms of understanding the complexity of getting robots to assist in movements, and I think that the Kleiman Jones work was real instrumental for me in terms of really thinking about what is it that this technology really offers to individuals and what's lacking. And I'm excited with the opportunity to move ahead and to really think about how we might best train individuals with these cognitive strategies to facilitate that transfer. And it was very enlightening for me to have people, a year or so later saying, yeah, I still use them. Yeah. Stop, think, do, check. Yeah, I do. Yeah, and it's really helped to decrease my frustration level, et cetera. So, it's been a positive experience for me.
So this is Veronica. Thank you very much. That was an awesome presentation. I'm just curious, in your future research, are you going to continue to promote the use of robotics with the ALPS system, which I love, or do you think the ALPS alone is what's needed? I'm just curious what you're going to do in the future.
Yeah, well, I think we really need to test both. I think one of the challenges with just doing ALPS alone is getting that number of movement repetitions with practice. And there has just been so much money and so much effort poured into robotic technologies that I think if we don't do something to try to facilitate that transfer of skill, that it's never going to be a technology that is well accepted and used across rehab institutions. And I think there's great potential there. I think that understanding ALPS by itself, or ALPS in conjunction with conventional therapy and ALPS in conjunction with robot therapy, are certainly two different areas to look at. And I think it all is needed. I think that it provides a little bit different focus than the co-op strategies as they've been applied so far with individuals after stroke. But it also doesn't require the same level of instruction and adherence to the co-op model. So I think there's a little bit more leeway in terms of, how does it work best for your patients or your clients? That's a great question, Veronica. Thank you.
Great. Thank you for your presentation. It's really good.
Thanks.
Are there any other questions? Okay. Well, thank you, everybody, for joining us. And for some of you, we'll probably see you in Chicago at our annual conference. And if not, our next virtual happy hour is probably happening next year. So we get a little bit of a break. But thank you so much, Dr. Fasoli. Thank you to the Movement Task Force Group for helping host our virtual happy hour for this month. And have a good evening.
Thank you very much. I appreciated being here.
Thank you.
Bye-bye.